So, welcome back to the latest episode of Taking Charge of My Cancer podcast. And I have a really great guest with me today is Dr. Olayinka Ogedengbe. Hopefully, I said it right. She is a passion oncology certified advanced practitioner provider, born and raised in Nigeria. She moved to the States in 2007 when she joined the UF Health Organization. She has worked in numerous roles and most recently as an advanced practice provider since 2019. She graduated with honors from the University of Chamberlain. Her exceptional care has led her to being nominated twice as the Advanced Practice Provider of the Year in 2021 and 2024, a testament to her professional excellence and dedication. She enjoys reading, watching action movies, and watching football in her free time. She's happily married with 4 children. Her dedication to high quality, patient centered care has made her continue to advocate for patients regardless of age, race, or economic status. So, thank you so much for being with me today.
Thank you for having me.
Absolutely. So, Yinka, what inspired you to become a nurse practitioner and especially in oncology?
Well, thank you. Well, my quest to enter nursing was ignited in 2010 after 80's 7.0 magnitude earthquake. So I thought of how I could help, which led to my passion for more education. So I got into oncology, to be honest with you, not by choice, but by divine circumstances. And I believe this was ordained by God because I needed a shift to accommodate my family needs. So I started as an infusion nurse and love the patient population. They are great. And I was given the opportunity to work as an advanced provider since 2019. And believe me, every day I love it and I love it. And it's been wonderful.
That's awesome. You're absolutely right. Sometimes you get these colds. Um, I was same situation, like I've been a PT for a while, and I was just doing orthopedic and sports medicine. And that was an opportunity for grow the oncology program here at my plaza. And when they approached me to see if I wanted to do this, I'm like, well, really, I really don't know. I really don't know anything about oncology. And I came and shadow one of my colleagues who was doing that, and just totally fell in love with the patients.
Yeah.
So,
Yeah.
and I've been doing this for 15 years already now.
Wow.
I won't go backwards. Like I absolutely love every minute of it. So yes, you're
Yeah.
right. Like
Yeah. Same
right
here.
call. Yeah,
Yeah.
exactly. Um, can you walk us through what is a typical day in your role when you see patients?
So my role is it's centered around the patient. So what we do is we clear them before receiving their treatment. And when I say clear them is we see them, we get labs, we ask them questions about toxicity to make sure they are tolerating this treatment well. Sometimes we may have to dose reduce to make sure their labs are appropriate and they are doing well. So I work closely with nurses and also with our oncologists here. And also we also go into like my chart where patient will send questions for that clarification. So we work closely with the nurses. They send us questions, concern of patients. Sometimes we have to call them for abnormal labs. We want them to do this. So everything is centered around the patients.
Okay, that's great. So, what are some of the most common misconceptions that patients have about cancer treatment?
So I hear that a lot, but the one that I hear the most is eating sugar causes cancer. And some people will say, oh, clinical trial is very risky. So, but that's not true. Patients are being monitored closely. You know, if there is no clinical trial, only God knows where we'll be today. And eating cancer does not cause, I mean, eating sugar, excuse me, does not cause cancer. And having chemotherapy does not mean that patient has poor prognosis. No, all these are myths, and looking at cancer as a stigma is something also that I've noticed. So eating sugar will not necessarily cause cancer. There are other reasons why patient develops that. And clinical trial has been shown to have saved lives. and he has been shown to have, brought, oncology to where we are today, especially in targeted therapy. So those things are well monitored. So any opportunity that I have, I try to correct some of these misconceptions so that we see things the way they are and try to help patients understand better.
So what are your thoughts about, so we know like sugar doesn't fit cancer, but how about like just it's the glucose, right? We know that, cancer can be a metabolic disease as well, right? Because definitely it's affecting your metabolic system. So how do you think that would be a good advice anyway for patients who are going through cancer to try to really watch, like how much
So,
do you take
so
regarding
anything that is in excess is not good, point blank, period.
Mhm.
You know, so not just sugar by itself. What about drinking too much water too? Anything in excess is not good. Or anything that can cause inflammation, it's not good. So I always tell patients to eat right, eat right and exercise and stay fit. So that has always been my go-to.
Okay,
But not necessarily just focusing on sugar by itself,
I
because
got
there are other things that you eat that also can convert into into glucose,
you. Yeah, yeah.
So just focusing on sugar by itself is not enough, but eating right, that would be great.
Okay, great. Um, how do you help patients navigate their diagnosis and treatment options?
So that is huge. When these patients are coming in, they are coming in with this diagnosis, they are so confused. They don't really know so many things. They are confused. They are checking Dr. Google's, family members, everybody bringing the. So it can be very, very challenging. So as a provider, what we do, we want to ensure that our patients are well informed. We want to tell them what the disease is, what stage they are, what are the treatment options that have been tested and proven to help in their case, and what are their chances. So we try to let them know, is this a curative one? Is this the one that we just have to control the disease? So we try to let them know from the beginning. And that can only be done through effective patient-provider communication. So which sometimes you may not even achieve at the first visit. So even after the first visit, I'm so glad that we have my chart so patient can go back and forth and communicate their concerns. So education is huge. So we try to educate them about their diagnosis and treatment options out there, and also give them resources that can help them to know what we are talking about.
Okay. Um, are you able to, do you guys usually refer them to like nutrition, physical therapy, any other, what is the interdisciplinary team that you refer these patients to try to help them overall to stay fit and eat right and keep up their activity?
Yeah, that's a very good question. Cancer care is multidisciplinary. We need a lot of people. So like you said, the physical therapy, medical oncology, radiation oncology, clinical psychology, social workers, the nurses, the pharmacists. So everybody is working together. So let's take, for example, breast cancer patient. I'm so happy with, I think there is this trial that they are doing with fatigue management, where they come in for physical therapy. That is huge because patient believes, some people think that when you have cancer, you shouldn't be doing things like that. I'm like, oh no. So I'm glad that we are putting things like that in place for patients, because even patients with end stage, most of them don't really die from the cancer, but they die, from not being able to move because they're on pain medicine. They are just staying there. The muscle that you don't use, what happened is wasted. So we do utilize physical therapy. They are a huge part of our team. Radiation oncology, they are a huge part. Clinical psychology also to kind of help patients get through this process. And also social worker, they are huge. I mean, I can just name them. So it is not just the oncologist that we need, a multidisciplinary, professional, interprofessional, collaboration to kind of get patients to where they need to be.
Okay, very good. Um, how and what role does palliative care play in oncology, and how do you approach this with patients when we're talking about just palliative and not curative?
So palliative, like me, I always believe that palliative collaboration should start from the beginning. It's not until when we think there is no more options for the patient. Because if we start that from the beginning, it helps the patient. So their role is huge in oncology because it includes improving quality of life by managing symptoms, addressing emotional and spiritual needs, and discussing goal of care when that time comes. And also further, especially when further treatment is not yielding the desired outcome and patients experiencing toxicity because of disease progression. So incorporating palliative role from the beginning is great when patient is still up and going, so that when they get to that point where we know that, okay, the treatment is no more yielding the result that we desire, and patient is getting more toxicity, talking about that will not be challenging because they're already part of the journey from the beginning. So palliative role is huge in oncology setting.
Okay.
And you ask the question, you say, how do we approach that? So we used to have palliative in outpatient here, but not recently. But we do have them inpatient. So whenever we need like goal of care discussion, we bring them there. But our social worker here, they have been very great, to kind of get involved with our patient, especially the emotional aspect of it. And also clinical psychology has been huge part of it for us too. And we also utilize support group for these patients populations.
How about your nutritionist? Do you refer everybody for
Yes.
nutrition?
Not everybody. But for example, the head and neck cancer patients, that as the treatment continues, eating is huge. Those people from the beginning, we do that. And there are some patients that they just don't, it can be challenging. You don't know what to eat, what not to eat. I'm doing this, I'm doing that. So some of them, we do refer them for nutritional consult.
Okay. But you still implement, or you're still educating them about, like you mentioned before, like anti-inflammatory diet, regardless, correct?
Yes, yes,
Yeah.
yes. And we do have like a little pamphlet up here about what to eat during chemo, stuff like that.
Okay. Are you familiar with, or what is your experience, and if you know more about fasting prior to chemotherapy?
I've seen that lately. I've seen where some of my patients are doing this. I support it if their health goes for it, if they are able to do it. Let's look at it. What does fasting do? Even let's look at somebody that doesn't have cancer. Intermittent fasting, I've seen some people using it, for weight management to stay in shape. So it's like using the excess fats, right there, getting rid of it, stuff like that. So I support if patients is able to, and their labs permits that, and health-wise they can do it. But where I don't support it is their labs are not permitting it, and quality of life is being jeopardized because of that. Like somebody having low blood sugar and they are still very adamant they have to do it. They have extreme fatigue, they can't walk, they can't do things, and they are still very adamant. So I believe in balancing everything that we do, letting patients be well informed about what this do and how this can help them and how this can harm them also, if it comes to that.
Okay, perfect. What recent advancements in cancer treatment excite you the most?
Oh my gosh, yes, that is targeted therapy. I love that. Immunotherapy, and also this just individual tumor generic profile that getting is, okay, this is what you have going with this thing, the driver, that really interests me. And you can see when you use the right medication for the right, you can see the results, and you just, you're able to talk to the patient, oh, we got this, giving them that confidence. So yeah, that really excites me. So I can't really wait to see where we'll be going in the nearest years.
If you want to explain on Lyme terms for some of the audience that does not differentiate between like, regular chemo, targeted chemo, immunotherapy, how would you describe that in Lyme terms?
So in late time, this is what I tell my patient, because even people that are getting immunotherapy, they're like, oh, I'm getting chemotherapy. I'm like, no. So I try to tell them that the chemotherapy kills the good and the bad, But whereas immunotherapy wires your immune system to look for the cancer and fight the cancer. And sometimes we have to use them together, because sometimes immunotherapy may not be able to identify the cancer. So the chemotherapy, we kind of break it down for them to see so that they can go ahead and attack it. And whereas targeted therapy is like, this receptor is what I'm looking for. And once I can get that, and we know that this is what is causing your cancer, so the targeted therapy just goes straight to that thing, and it's just for that thing. And since we know that is what is driving this, that helps. So that cannot help patients to see what I'm saying.
That's very good way to explain it. I may use that when patients ask me about that. Because, again, they come to you guys. First of all, a patient get diagnosed with cancer, right? So the first thing in their mind is, I'm gonna die, right?
Yeah, yeah.
And I have a family or kids or grandpa or parents to take care of, whatever responsibilities they have, and that's all they can think of. And then they come to you guys for an appointment, and all these medical terms and these genetics and these tumor markers and all this information, and they see the surgeon and they see everybody in the multidisciplinary team, and all this just becomes like overwhelming, right? So
Yeah,
they come
yeah.
to us for PT, usually on a pre-op referral coming from a surgery. And they're like, I just know I may have to have chemo. I'm pending on this test and that, and I really don't know. And I think I'm gonna have some chemo, but they're talking about some radiation and then surgery, and it's like really overwhelming for them. So we try to explain to them, no, this is kind of like what is going to happen. So I'm going to start using that terminology with them. So they come back after work, like, I need to weigh on this oncotype to see if I'm going to have therapy. I don't know what this oncotype means. Actually, maybe take me to the next question. Will you explain to the audience what is this oncotype?
So thank you. So now we're talking about breast cancer patients. So like you said, let's say after surgery, then they discover that this patient has ER, which is hormone receptor. This patient also has HER2. So with the ER, okay, so it was T1C. Okay, we want to see, we know that this patient will benefit from endocrine therapy. Can this patient also benefit from chemotherapy? So that's why we do the oncotype. So the oncotype results, so that is recurrence score, we call it RS. So when it's less than 25, and depending on the age, we don't recommend chemotherapy. And we are talking about distance reoccurrence, not the local area. So with that, if it is less than 25, we just say, okay, you could just take your either anastrozole, tamoxifen, depending on the age. But if it is above 25, then we are like, okay, chemotherapy is recommended. So that is to determine who gets chemo and who doesn't get chemotherapy. Yeah, to kind of reduce the risks of this thing coming back.
Is that now a standard of care? Everybody gets an oncotype?
No, so oncotype depends on what type of cancer the patient has. Even though we're talking about breast cancer, there are different types. And what are the markers? So for somebody without ER positive, we want to do that. So ER positive, yes, but somebody with like stage 1A is not recommended.
Okay.
So it's not a standard of care for everybody, but anything from like stage 1B, 1C, stuff like that, we want to see.
Okay, so it's more 1C, then stage 2 and above, and if for sure they're ER positive.
Yeah.
Okay, good. That's good to know. You just tell me something else. So here you were talking about how excited you're about target and immunotherapy, and that's my next question. How was immunotherapy and target therapy changed the landscape of oncology?
Oh my God, these two have significantly changed the landscape in oncology by offering more personalized treatment approaches, providing new treatment options, improving survival rates, and in most cases, reducing toxicity. Like I said, chemotherapy comes with the good and the bad, and especially in a frail patient. You are looking at them. I'm not sure this patient can even tolerate chemotherapy. We want to fight the cancer. We don't want to kill the patient. The immunotherapy has given us that opportunity, that approach, especially in our elderly population, that we know they can still be here longer. So it has really improved survival rates and also decreased, treatment-related toxicity. Immunotherapy also comes with its own toxicity, but you can't really compare it to in those days that all we have is just chemotherapy.
Got you. That's perfect. That's good to know. So that brings me to something. So I'm not too sure how much you know about what we do here in PT, but one of the things that we do is a body composition test. It's an IMAGI where we can see skeletal muscle mass, body fat mass, water, so forth. So sometimes I come across patients who come maybe in a pre-op setting from breast who are planning to have chemotherapy, neoadjuvant chemo. And their skeletal muscle mass is bad. It's like they're almost cachexic, like we're talking about 20, 30 is bad. What's the best way? Like, how do you guys can modify that standard of care regarding treatment? Are you going to still giving them that chemo regimen that you will give to somebody else? Or how do you modify that situation in somebody who is really having a very bad skeletal muscle mass and almost in that verge of being, cachexy and fragile?
So when we have a patient that is very fragile, like I said, we've had to, depending on their profile also, if their profile accepts that we can use immunotherapy, I have seen where our oncology, we cannot start with immunotherapy to see how they will tolerate it. And if their profile and the type of cancer that they have does not permit immunotherapy, we will have to discuss with the patient. Sometimes we have to start at a very low dose to see how they will tolerate it. So if they tolerate it well, because sometimes, even though we are looking at the symptoms burden, the symptom burdens sometimes might be because of the disease, so you have to be able to balance it. Is it the cancer that is driving this? So if we know that it is the cancer that is driving this, so this patient will not get better until they are treated.
Okay.
So how do we treat them safely? So what we do is sometimes we may have to reduce the dose. And if it is, disease burden, you see that patient is getting better, then slowly we can titrate the dose up. That's what we do. And sometimes, depending on how bad they are, sometimes we may have to admit them to treat what can be corrected first before we initiate chemotherapy.
Got it. So you'll put like more in a higher regimen of a better nutrition, fluids, those kind of.
Got it. Fluid, stuff like that, to make sure they are in a state where we can safely give them treatment.
Got you.
Yeah.
What resources of support system do you recommend for oncology patients and their families?
So there are a lot of support groups out there that these patients don't really know. So I always make sure they see the social workers, because there are some that I don't know myself. So the social worker is a very great resources for us in that area. And also top cancer organization website, they have like patient education center about supportive care, and also financial assistance through pharmaceutical companies for affordable drugs, and organization for financial, they call it FAPs, FAP, stuff like that. So telling patient about those resources really help. Yeah.
Okay, very good. How do you manage the emotional toll of working with cancer patients?
As we all know, cancer comes with its own. It comes with both psychological and physiological demands, on the patient. So the first thing you want to do as a provider is to acknowledge their feelings, acknowledge that this is real, provide them with active listening, and offer resources through support group or clinical psychology, or if that is not helping, medication if needed. And also, above all, is setting realistic goals. You want to tell them the way it is, but at the same time, you want to let them know that you are here for them to help them get through this. And if getting through this will be going to hospice, let them know that it's still going to be a dignified one. The autonomy will still be respected, and it will still be, they will still be well taken care of. So active listening is huge, and acknowledging that what they are going through is real is huge too.
How can we improve that? Many times, this is a crazy times for healthcare, you know that.
I
And
do.
and then we are like, you guys are super busy. And sometimes, the provider comes in, the attendant, and is like, 5 minutes with the patient, 10 minutes with the patient, and they gotta run to the other patient. So what is your suggestion? How can we improve that? Because that's the frustration patients get, right? So they're like,
It is.
you talk about active listening, but it cannot be active listening if you need to get in and out of the room in 5 minutes, right?
You're right. You're
And
right.
by the
That
time
is,
the patient is going to ask questions, they're already running out of the door.
yeah.
So what is your suggestion with that?
So that is where healthcare system needs to be better. We need to be better. And another thing that we do here, we have what we call distress screening tools. So the nurses will do that before the provider comes in. So that is a red flag, because as I'm opening the patient chart, I can see the score. So the score is already flagging me that something needs to be addressed. So things like that, when I come in, I pay attention to that. Okay, I found this. What is going on? So I talk to them about it. Then I offer social worker or offer clinical psychology or adjust their medication. So we do have tools that can kind of flag the provider that this is not a 5 seconds visit. This
Okay.
is a visit where you might need to address something like this.
Okay, good. So they know ahead of the time that they need to spend more time.
Yes. So
Okay.
yes, we do have that screening tool that once you click on the patient chart, that's the first thing that pops in.
Okay, great. And then go
Yeah.
back to your emotional toll. How do you manage yourself, this emotional toll, dealing with patients with cancer every day? What do you do for?
You know, you know, this patient, they have taught me a lot. They've taught me to know how to be more appreciative. But even though I don't want to get attached to patients,
We
there
do.
are some of them that you've known them, you just get attached to them. And will I say, have I cried? Yeah. And I think it's okay for me to cry sometimes. And have I gone to somebody's burial ceremony? Yes, to just give them that respect and that honor. So I think it's well balanced here. I have great support here. The people that I work with, the doctors and my co-workers, I have great support. And apart from that, I have God too, So I don't try to take work home. And if I do, I try to do like listening to music, reading books, things that can help me to uplift, my emotional well-being also. So I try to invest in that. Yeah.
Okay, perfect. If you could change one thing about oncology care, what that will be?
Ooh, if I could change anything, believe me, I would want all cancer to be targeted treatment. No more one pill fix all. No. If I
Okay.
can change anything, I would want to personalize medicine more available, and not only available and accessible. Even there are some that are available, but they are not accessible to this patient. These things are huge. They are very costly. So I would want it more available. I know you said one thing, but I want it more accessible too. So which will lead to more targeted therapies and improve survival. So that is my goal. And I hope that we have more resources, government can give us more money into oncology so that we can, eradicate, if that is the word to use, eradicate cancer.
That would be great. Awesome. Is
I,
anything else you would like to add before I let you go?
no, I just want to say thank you for having me here. This is huge, to get it out there for our patients. So let's just keep on, advocating for a better patient quality care, and above all, accessible to, quality care should be our priority too.
That's awesome. So that has been super fun. Thank you so much for doing this
Thank
with
you.
me. I learned a lot. I'm sure the audience will really enjoy it. I really appreciate it.
Thank you so much for having me. I appreciate that.
Absolutely. Have a great evening. Bye-bye.
All right, you too. Bye-bye.